this session of Basic Approach to Chest series, we learn what is consolidation, how to report, and its differential diagnosis. Coming to the basics, consolidation means replacement of air in alveoli by abnormal material. It could be anything like pus, water, blood, cells, etc. So when that happens, there is increased opacity on chest X-ray. So let me draw the alveoli. These are the normal air-filled alveoli. The inside is black. Whenever there are nodules, there will be partial filling of alveoli. That will cause appearance of nodules on chest X-ray. But when these alveoli are completely filled with such abnormal material, like I am drawing now, when they are completely filled, it's called consolidation. That means they present like consolidation. So in a background of completely abnormal material filled alveoli, there will be air bronchogram seen. We'll see that shortly. So this is how nodules and consolidation appear on chest X-ray. So here you can see multiple variable sized. Some are confluent, some are discrete nodules. But here you can see these fluffy airspace opacities, or it can be complete homogeneous opacities. So nodules coalesce to become consolidation in later stages in many of the cases. What are the characteristics of consolidation? It's usually present as homogeneous opacity. They obscure the vascular markings of lungs. So here you can see vascular markings on right side, and left you can't see. They present with silhouette sign positive with the adjacent borders of heart or diaphragm, and there will be air bronchograms which may or may not be seen. Coming to what are air bronchograms, here you can see these thin black lines here. So those are patent bronchioles, that is, which are air filled, that's why appearing black, which are seen against completely opacified alveoli in the background. Like I drew, now I am drawing the diagram again. You can see here that alveoli are completely filled with abnormal material. Like this, many of the alveoli in the background are filled with abnormal material, and the airways are filled with air. So they will stand out as black structures against the white opacity or background. So that is called air bronchogram. This is a sign of consolidation. Coming to consolidation, it can be focal or patchy like in the first X-ray, or it can be diffuse like in the second X-ray where whole left lung is involved, and depending on that they will seal out the adjacent margins. So later stages, these consolidation may show airway breakdown in the center. That is, there can be resorption of the opacities by destruction of lung parenchyma focally. So those areas will later form cavitations. Whether they can be thin walled or thick walled, we have to note it down. If you see a opacity like this, how to differentiate it from consolidation versus atelectasis? So in consolidation, there won't be any volume loss. In atelectasis or collapse, there will be volume loss features like tracheomediastinal shift to the same side because of the pull, rib crowding because of the collapse, and they will be pulled up hilum, etc. So here you can see heart is in midline. There is no shift in the tracheomediastinal structures. So how to differentiate consolidation versus a large effusion? So here you can see large effusion has the homogeneous opacity which shows tracking along lateral chest wall because of meniscus sign. But here you can see there is no meniscus sign. So here it is irregular spaced opacity. This is consolidation. And in effusion, there will again be mass effect towards opposite side. So the structures will be pushed to the contralateral side. Like contralateral tracheomediastinal shift will be there. Here again, heart is in midline. There is no shift. How can you see whether it's consolidation or whether it's a mass here? So there can be underlying mass under the consolidation, but usually if mass is present, there is mass effect also, and there is contralateral mediastinal shift, but not in all cases. So how to differentiate whether it's infective or whether it's because of mass or effusion or atelectasis? The main clue will be the clinical details. So if patient has something like cough, fever, increased counts, then you can look for infective causes. If there is associated loss of weight, appetite loss or hemoptysis, then consider mass as a possibility, mass or neoplasm. If the patient is known case of cardiac disease with cough and history of TB, so look for effusion. If old history of TB is present and if foreign body history is there, look for atelectasis. So what are the causes of consolidation? Once you are sure it is consolidation, not a mass effusion or anything, you have to look at the cause. So infectious causes like pyogenic, fungal, viral and tubercular can cause consolidation. Non-infectious causes like pulmonary edema causes perihilar consolidation. Aspiration causes right lower lobes consolidation, and hemorrhages can cause consolidation, also ARDS. Once you see a consolidation on X-ray, how to report? So taking the same X-ray as example, homogeneous opacity is seen in left upper, mid and lower zones, silhouetting the left heart border, left hemidiaphragm and left costophrenic angle. Few air bronchograms are seen within. Discrete nodular opacities are seen in left upper zone and right lower zone. Confluent nodules are seen in right lower zone, which later form consolidation as we saw. Don't forget to mention that there is no tracheomediastinal shift and no features of volume loss. That will give you a good diagnosis. This was all about how to go about consolidation in a chest X-ray, and in this series I'll be putting how to report the chest X-ray. Follow our channel for more such videos and please share, like and subscribe to our page.